Good morning, everyone. It's my distinct pleasure to introduce our esteemed lecturer this morning, Dr. Manpreet Singh. Dr. Singh brings us an exceptional blend of clinical expertise, academic brilliance, and groundbreaking research in the field of psychiatry. Dr. Singh has recently embarked on a new chapter in her illustrious career at the UC Davis Department of Psychiatry and Behavioral Science. After 16 remarkable years at Stanford University, she now dedicates herself to building a pioneering youth mood disorder program at UC Davis. During her tenure at Stanford, Dr. Singh led the Pediatric Mood Disorder Program and Pediatric Emotion and Resilience Program. Is that right? Lab, okay. Her groundbreaking multidisciplinary research has significantly deepened our understanding of the neurobiology underlying mood disorders and related psychiatric conditions. She has been at the forefront of examining neural circuits dynamics, genetics, and the impact of early life and family environmental stress to identify risk factors and developed new therapies for youth mood disorders. She is also the author of a renowned clinical handbook on pediatric mood disorders, which sits on my desk. It's a very highly useful and relevant reference. I highly recommend it. So please join me in extending a warm welcome to Dr. Manpreet Singh. Thank you.
Wow, thank you so much for the kind introduction and warm Montreal welcome. I grew up in Canada, so I feel right at home, and people wondered why and scratched their heads. Why would I come to Montreal in the middle of December? And I said, it's nostalgia for me, growing up in Calgary and then Toronto. So thank you again for the kind welcome. My hope today, if with us in our conversation, is to talk about a condition called bipolar disorder. One considers this a condition that is lifelong. If you have it, then you're likely not to be rid of it. There are no cures. And so how do we understand the condition? How do we understand how we treat it after we've appropriately and accurately diagnosed it? And how do we wrangle with the difficulties that come along the way in terms of treatment engagement with patients and families? Here are my disclosures of potential conflicts of interest. I do collaborate a lot, and I will try my best to highlight, in any case, if there are any specific conflicts of interest in my slides. So let's talk first about how we harmonize an approach to diagnosing and treating bipolar disorder early and over time. We'll spend some time talking about specific barriers for early treatment engagement and response. This has both implications for clinical care, but also for research, as we think about ways to translate research into clinical practice. And the hope is that we can integrate an evidence-based approach into the continuum of care over time. And that requires partnerships between researchers and clinicians. And goodness, I have to tell you, the innovation horizon for psychiatry and neuroscience is very, very bright. There are a number of people who are very interested in working with us in psychiatry to develop the best next treatments. Drug discovery in psychiatry in the past has relied a lot on black swan situations, which are unpredictable events that are beyond what's normally expected of a situation and has potentially high consequences or significant consequences. Unfortunately, these black swan events are quite rare, and although they have a high impact, there's often a widespread insistence that they were obvious to begin with. Lithium is an example of a serendipitous discovery that we realize now, oh, of course it's a great treatment for bipolar disorder. I will discuss with you what black swan discoveries tell us and what sensible medicine approaches tell us, so that you can decide with me what we need to do to move the needle on better treatments for youth with and at risk for mood disorders to meet the clinical challenges and unmet needs of these patients. So here is a very typical tweet from a child psychiatry perspective that we get all the time. These are common patient problems or parent problems. My kid says he is depressed. I already took his phone away. Is there anything else I can do to get him out of this phase? Right? We have a lot of kids now in this generation engaged in social media, and really we're struggling to figure out how to balance engagement with these kinds of technologies and emotional and social well-being. And sometimes it's not as easy as just taking a phone or a social media exposure away. If you imagine, kids are distressed and also dysregulated in a variety of different contexts with a variety of different triggers. And so understanding more systematically what those triggers are to be able to make some causal inferences requires us to be thoughtful about how we design those experiments. Because causal inference requires us to do some randomization, some experiments where some people get the intervention and some people don't. It's only through that method, that scientific method, can we make the inferences that we need to make about interventions and their effects. Understanding the lifelong nature of bipolar disorder, I think, is very important. And I think, generally speaking, most of us know now, because of much research and attention that's been focused on this area, in part by folks in your department, and the hard work that's been done here and abroad. We now know that mood disorders and bipolar disorder can start early. In a retrospective large study of adults with bipolar disorder, most of them described actually having the onset of symptoms before at adulthood, usually in childhood or most commonly in adolescence. It's a persistent condition, and especially when it starts young, it means the lifespan of it is longer, and you have more lifetime chances of lifetime episodes. And that can lead to more difficult treatment engagement problems, poorer prognosis, and an increased risk for suicide compared to an adult onset of the condition. It's being recognized more, and so there's some concern that we're overdiagnosing it, if you will, because we're seeing more research attention to it. But in fact, we are seeing, and we've done a better job with a lot of attention to validating scales to be able to understand this condition and describe it in a developmentally sensitive fashion. So, 20, 30 years ago, people didn't believe kids could get sad. Can you imagine that we didn't believe children could get sad? At this stage, we don't really doubt that. We understand that it happens, and we try to understand it from the perspective of a child. And the language a child uses will be potentially very different. A 4-year-old isn't going to say, "Oh, doc, I'm melancholic." Right? They're going to use different words, but they're also going to demonstrate different behaviors. It's why irritability is considered a feature or an early sign of a potential mood problem, whether bipolar or depression. And although it may not be specific, it is a sensitive early symptom for us to be considering. These conditions, like bipolar disorder and depression, are often comorbid, especially when they manifest early. They have other co-occurring conditions, sometimes that precede, like anxiety and ADHD, sometimes then continue to co-occur or evolve into things like substance use. And so then you have this unfortunate diagnostic uncertainty that comes about as to what exactly are you looking at? Is it ADHD? Is it bipolar disorder? Is it trauma? How do we systematically evaluate these issues? And fundamentally, bipolar disorder is a disorder of energetics, and it is episodic. So it doesn't happen persistently in the ways that we see sometimes, for example, chronic irritability manifest. This is in reference to Ellen Liebenluft's work that demonstrated that chronic irritability very much does not go on to become bipolar disorder. It tends to be a precursor to more unipolar depressions. Symptoms can be managed. That's the good news. The silver lining is that we have solid evidence for acute management of symptoms, but what do we do after we managed acutely mood stabilize a patient? what happens next? Many of the medications we have available to us are actually quite problematic from the perspective of side effects. So how do you convince a patient and a parent that you may need to be on this medication or treatment for your life, especially if we don't really have a lot of evidence to support the long-term management in a prophylactic or preventative way? We believe and we presume, and our guidelines suggest, that after we treat an acute any mood episode, whether it's depression or mania, that we continue treatment, because the treatment is actually there to prevent the next episode. And there are some very reasonable observational studies that support that contention, but we need more high quality evidence to support it, because it has significant implications for clinical care and treatment planning. Then there's this really other interesting aspect of child and adolescent psychiatry and youth mental health, is perhaps why we're all here today and why we care about working with children and adolescents and youth more broadly, is that maybe if we intervene early, we could prevent these difficult and disturbing and potentially impairing symptoms from persisting and continuing into adulthood. Can we catch kids at a critical sensitive window of development, whereby their brains are more perhaps conducive, more likely to have a response to treatments, and then potentially pave the path for more well-being over the long term? This has implications, again, if you recognize that mood disorders can start young. So if your runway is long because you started young, wouldn't we want to prevent that runway from being as long, and extended as possible? We want to shorten and attenuate that. So this is really one of the reasons why you and I all come to work every day, is that we want to really realize the dream of being able to prevent psychiatric disorders from continuing into adulthood. There are some additional problems or challenges that we face, and these are things that we're grappling with in the field that no handbook per se could necessarily address, but are continuous issues that we need to engage with and do research with. Screening. No one screens for mania routinely in kids, right? And if we did, maybe we'd be prone to overdiagnosing kids. If you screen people, you tend to have more of a positive affirmation bias than a negative one, but a screening tool could also be used to rule out a diagnosis, and it could at least put into a clinician's mind, hey, I may have some biases about the fact that kids can't have mania or kids can't get sad, and maybe I need a tool to help me decide whether or not this is actually what I'm seeing in clinical care. There is a new tool, the Rapid Mood Screener, that's been validated in adults down to age 18. It's a 6-question brief screening tool that folks in America are working on validating, and or it's already been validated against the MADRS, but it also, or the MDQ, but it's also being evaluated more systematically for its potential preventative applications in primary care offices. I don't know if any of you have primary care screeners in family practice or general practice clinics where depression and anxiety are screened. But in the US now, we're actually routinely screening for depression using the PHQ-9 and anxiety using the GAD-7. So these screeners are now routinely implemented in primary care doctors' offices. What do we do when we see a patient screen in? We have the problem of underserved and underutilized services. We don't have enough to meet the demand. So universal screening may be a challenge for us to implement in kids, but we do need to think about ways to alter our mindset away from ruling it out. Diagnostically, we are really not in the business of routinely measuring symptoms and tracking them over time in our clinical encounters. It would be great if we could find ways to systematize that, because then we could actually have a electronic medical record, a database, if you will, that has informative information that could be utilized in larger data sets and potentially used to understand what are the factors that lead to treatment response or relapse. We don't have a diagnostic test for bipolar disorder. We don't have a blood test that says it. At this current state, we rely heavily on a clinical diagnostic interview, which tells us actually a lot. And replicably, Emil Kreplin's observation of manic illness, manic depression is so coherent and so consistent across the centuries that one need not debate the existence of mania. We might debate the prevalence of it. It's still only 1% of the population. It doesn't necessarily just occur in certain parts of the world. It happens everywhere. It may be less frequent in certain places, and we should understand why. And it's been a challenge to implement measurement-based care, even though most people who study bipolar disorder and clinically follow patients with bipolar disorder will ask them to either on paper, pencil, or on an app chart their moods. And the reason why that's important is that this condition is a condition of energetics, but it's also episodic, so it has onsets and offsets of depression as well as mania. And what is mania? I'll show you in a minute, and in terms of a neurobiological framework. But before I do, I wanted to just mention treatment. Treatment is also, unfortunately, even though we have lots of treatments available to us that have been studied through randomized controlled trials, so a very, very strong evidence base for treating bipolar disorder in youth down to age 10 even, no one size fits all. And it's very difficult for us to know which treatment works well for which child. And so we need to do more personalized treatment matching. And we really don't have anything for more spectrum conditions, which are very common in youth. Like, for example, a kid may not meet criteria for a week of manic symptoms every single day for 50% of the day or more for at least a week, or been hospitalized because of it. They might have 1 or 2 days or 2 or 3 days. And how do you assess and treat or evaluate those hypomanic symptoms? Psychotherapy, of course, to begin with, and I'll show you some data on the importance of that and the potential value of that in preventing relapses. But it is also another open and unmet need. Kids experience a lot of side effects. They need better, we really just need better drugs that aren't associated with weight gain, metabolic syndrome, and excessive sedation. Sedation has the problem of potentially also making people sleepy. And so it's a really challenge for the kids that are in school and finding themselves sleepy during the course of the day, and it has an academic impact. And there are some treatments, frankly, that when you don't realize it's mania, might induce mania, like antidepressants have the capacity to do that. And so we've been studying that as well. Another major issue in this work that we do in youth mental health is treatment engagement or adherence. Most patients, unless they're sort of prompted to, don't tend to want to keep on their medications. Melissa Del Bello did a 12-month follow-up study on first episode mania and found that after 12 months, only about a third of the kids that were treated stayed on their medication a year later. So the adherence rates are very low, and that has implications for, again, having your best shot at really doing the intervention that's necessary. And then kids are they enjoy being hypomanic or manic. It might get them into a really very reputable school, or it might help them be socially popular, or it might help them in other ways. And so what matters to the patients in terms of their goals for engagement in treatment is really important, in addition to the education about what happens when you leave mania untreated. So Anthony shared the handbook that provides sort of a heuristic on how we treat childhood onset mood disorders. They present variably over time, and we try our best to understand that even though comorbidity is the rule, that may lead to non-specificity or trans-diagnostic ways of thinking about kids. Nevertheless, we want to be parsimonious in our treatment approach and try one medication at a time or one change at a time clinically, so that we can make sense of how we're actually helping. So what happens when we are diffuse in our formulations of kids is that we say, oh, they have a little bit of this and a little bit of that and a little bit of this and a little bit of that. When I went online today to see how medications are used in Canada, I noticed one article talking about how, you know, you get like a little sprinkle of quetiapine for everyone, sort of non-specifically and at subtherapeutic doses. And what would be the purpose of doing that if it's not actually targeting something specific? You could argue that it helps with sleep. It could help with the multi-domain symptoms. I get it. But until we have some really strong empirical evidence for why we want to use subtherapeutic doses, I think it becomes a challenge. Our goal ultimately is to get kids to feel well and be well for more days than not. But you know what happens when you have to try several things before you get to the right treatment? Kids kind of peace out. I don't want to deal with this. You know, I've grown impatient. I don't need you. I don't need to go through yet another trial. That medication sucked. This next one sucks too. I'm out of here. So we have only that opportunity when patients are treatment seeking, and we need the best tools that we can to be able to help them. Here's the sort of formulation of how I understand bipolar disorder from a neurodevelopmental perspective, and why it is not just complicated from the sense of symptoms are multiple in nature, sometimes cross over multiple different domains. There may be multiple triggers, environmental stress, the symptoms themselves, a genetic predisposition like a family history of bipolar disorder. They all sort of contribute to the brain's response, and there are very clear and replicated conserved neural systems that are engaged in mania and depression that have now been demonstrated over and over again. We see very clear connectivity patterns in the ventrolateral prefrontal cortex or inferior frontal gyrus, where you actually can track now the function of emotion regulation with circuit level connectivities to subcortical regions like the amygdala. The cerebellar vermis is an interesting one. I don't know how many of you know, but in neurology, we tend to use kind of a lesion-based approach in phenomenology. You knock something out in the brain and then you see how people function or behave, the lobotomy kind of way of thinking about the brain. But I'm going to shift it to something a little bit interesting, that actually we can learn something about really clear deficits in regions of the brain. There's this actual phenomenon called cerebellar affective syndrome. In the cerebellar vermis, if you actually see any infarct or lesion, you'll actually see phenomenology very similar to mania. How interesting. And very clearly, the cerebellum has played a critical role in many studies that we've done in bipolar disorders across the lifespan. So I include it in the network as well. And what you get is a variety of constellation of outputs that are, again, tuned with intervention. So it's really important for us to understand that this neurodevelopmental soup is what it is. It's carrying along, but as soon as you intervene, you're likely to see some sort of effect of that on the system. It is no longer a risk state, perhaps. It might be a consequence of intervention. So thinking about risk and development of illness and treatment are really important as we formulate and conceptualize this disorder over the lifetime. And again, the adherence piece too. If most of the kids aren't taking it, you have the advantage of really looking at a treatment naive population in kids, whether you like it or not, but that might actually be a little bit less confounded than adult data. This is how bipolar disorder presents across the life cycle. You've got a lot of distributions of episodes, but you'll note this is Kraplin's kind of perspective. This is, again, centuries old and still true today, that most kids, you know, in the adolescent phase have really more mixed states. They have these juxtapositions of highs, euphoric, cheerful, high, terrific, not your normal self, plus any additional energetic symptoms, sleep dysregulation, pressured speech, but then also the lows. And they occur oftentimes simultaneously. Some might regard these as agitated depressions, but they don't necessarily have to be. They could be depressions that are interspersed with rapid cycling, or again, energetic from the perspective of euphoria. I feel fine now, but I feel terrible in the next minute. Those rapid cycling features are very commonly observed in kids and create really a recipe for dysregulation. So in terms of our next steps, in my view, you know, we talk about lots of ways of conceptualizing conditions. I thought Tom Insel did a nice job of encapsulating in psychiatry research 3 potential areas of prevention. We need to develop more biomarkers for early detection, whether it's speech analytics to see how fast kids speak and how do we understand that kind of diagnostically. Is it a certain rate above which one would say, oh, this is clearly meeting diagnostic criteria? We still have to do that validation. Or it could be a biomarker like from blood, like mitochondrial DNA or oxidative stress markers or other exosomes that might show some sort of signal. Unfortunately, because bipolar disorder is polygenic, it's very unlikely that we're going to find a single marker, and we've been looking for biomarkers for some time now, but we're still importantly in pursuit of it because the diagnostic presentation, as I mentioned to you, is so difficult for so many people. In fact, it takes sometimes upwards of a decade before a patient actually gets the right diagnosis. Can you imagine waiting a decade before getting the right treatment for your psychiatric condition? That's a long time to have to wait, and a long time to have trial and error really erode trust in the system. Secondary prevention is when you have preemptive interventions for those at risk or in pre-symptomatic stages. These are the people who have clinical high risk or have a family history of bipolar disorder. We've been doing a lot of this work in collaboration with David Miklowitz that I'll show you. And tertiary prevention is still prevention. You might say, oh, once a patient has the condition, that it's no longer prevention. But in fact, the medical enterprise really thinks of treating after a patient has already developed a disorder in terms of prevention, because we want to prevent relapses. And so we need better treatments for people living with bipolar disorder that predict and track outcomes, but also better quality treatments that don't have the risk-benefit profiles that are currently in play. Okay, so what do we need to do? When do we need to do this? It's not just about what, but when. And people are really, again, evolving to earlier stages of development to the point where maybe we need to do something pre-conception. It reminds me of Bob Friedman's work in Colorado, where they were giving, supplements, in utero for mothers with schizophrenia. To try to reduce the likelihood of developing schizophrenia in those youth. And I mean, I think that our aspiration obviously is to prevent mental illness from, having its impact over generations. But these are very interesting opportunities. And now that we're able to do, for example, fetal MRI, we might be able to actually look in vivo in very novel ways to be able to understand how the brain might be developing even prior to delivery. And who will go on to develop a mood disorder and who will be resilient is really the fundamental question that we grapple with. We want to know, can we look into a crystal ball and tell patients, okay, 10 years down the line, this is what's going to happen? And so, really a family history of bipolar disorder is the model system we have used over the last 20 years or so to understand the risk syndrome, or the risk phase of developing bipolar disorder. And I show you a picture of my children at an earlier stage of development, just to remind ourselves that there are a lot of kids that have good days and bad days. That does not mean, even if they're at each other's throats, that they have some sort of psychopathology. And so we have to understand and contextualize normal development, even as we do these studies. And so having a control population is really important. I also wanted to just give a shout out to a recent visit I made to the Natural History Museum in DC, where they have an evolution exhibit. And if you go into the exhibit, they show sort of the evolution of brain development. And if any of you have seen it, it's quite remarkable the way that they've told this story. Do you know when in our evolution, of human evolution from other mammals, our brains grew the most in size? Any thoughts? Cooked food? Interesting. Any other guesses? Thumbs? Okay, so like, yes, having the ability to unwrap a piece of corn, like Omnivore's Dilemma. That's Michael Pollan actually talked about how corn was going to become extinct because it had ears, and unless there was a species that was able to open it and look at how much corn and corn syrup has become so much part of our daily lives. Well, in this exhibit, I mean, I'm sure there's multiple formulations, but in this particular exhibit, they actually tracked climate events with brain development. And what they found was that it was in moments of climate change, significant climate change, that was really problematic for species survival, when our brains grew the most. Why? Because our brains needed to have social cognition. We needed to rely on each other to be able to survive. We needed to huddle. We needed to problem solve on how to save ourselves from, devastation from climate change. So it is at those moments in our evolution, this is over thousands of years of evolution, where higher cortical functions actually evolved. Yeah.
Are you saying that our brains are getting bigger at this moment?
Exactly. That was my lead-in. You got it. That could it be, now that we're experiencing another climate event, could our brains even grow further? That remains to be seen. I feel like we are also doing things to hurt ourselves and our Earth. But in any case, I thought this was very helpful, because it also harkens to prevention scientists' work, like Anthony Biglin in Oregon, who spent his life's work actually looking at behavior games in school settings and tobacco cessation in kids, and has demonstrated that there are very clear experiments that have been done in school settings that have had not just immediate effects, but 20, 30, 40 years of longitudinal effects. So in the 50s, the schools in America implemented this good behavior game. It was kind of a point system to be able to essentially get kids to engage with positive reinforcement strategies. And the kids that were randomized to this good behavior game actually turned out to be very, very good, very responsible adults. Those who didn't get randomized or didn't get exposed to this game and had some liability towards delinquency ended up having delinquencies, validated, very well tested now, and tested over many years. So we have actually, and the point he makes in his monograph on the science of behavior change, called the nurture effect, is that we have tons of behavioral neuroscience data to demonstrate that our social capacity, our capacity to care for one another, is actually very adaptive. And we have lots of experiments to demonstrate, why we should do that over being coercive to one another. So a little side note, thought it would be of interest to you, and also a segue to understanding what keeps people resilient. How do we understand resilience? And our folks, colleagues in Mount Sinai have kind of done a nice job kind of engaging with kind of popular ways that we think about this. I don't have enough time to go through each of these circles, but you can kind of see these are very practical ways that we try to boost our own personal resilience. And we recognize that it's a complex and dynamic process, and it involves the ability to adapt successfully to adversity, stressful life events, significant threat, or trauma. And it's on a continuum and can be cultivated with a potential for change across the lifespan. Now, I want to make a quick comment about this. I've now dived into well-being literature and flourishing. The concept of flourishing doesn't require an adverse event to occur. Resilience really is a reactive kind of phenomena. You know, you have to have some sort of inciting event to boost your resilience. But now, as we're conceptualizing well-being as opposed to languishing, you might imagine that there are lots of different tools that we can now potentially implement into our studies of investigating resilience. And this translates back to, and I just want to give a shout out, Eric Nestler has done some beautiful work on looking at gene co-expression analyses of RNA sequencing data from brains of mice resilient to social defeat stress. And what he's identified in this study in Nature Neuroscience was that there's actually a gene network that's particularly unique to resilience. It's the ZFP189, which encodes a previously unstudied zinc finger protein. And it's the highest ranked key driver gene in that network. And overexpression of this zinc finger in prefrontal cortical neurons preferentially activates this network and promotes behavioral resilience. So these like basic experiments are really helpful because they help us understand how our brains are wired to potentially be resilient and how do we understand the consequent forward translation. Now we've also begun to look at single gene experiments and single cell experiments and doing transcriptional dissection of symptomatic profiles across the brain of men and women, for example, with depression. And Dr. Turecki was participating in this very recent Nature Communications article that just came out last month, in October, that really describes, you know, the fact that it might be the case that, you know, our capacity for managing stress is going to be sex differentiated. We've already known this, but to understand the cellular basis of it is very interesting in postmortem brains. Here, what I wanted to say is that we've also done something similar in kids with in the Philadelphia neurodevelopmental cohort, which was down to 8 years to 21 years of age. We looked at about 800 brains and developed a morphometric measure, kind of a summative measure of structural and DTI scans. And that morphometry measure was then again evaluated based on sexual dimorphism. And the idea here was that the brain isn't just wholly female or wholly male. Men are from Mars and women are from Venus. No, thank you. It's not like that. Our brains are highly, highly differentiated and regionally so that you might actually see differentiation even at the specific regional levels. So we provide this map, and then we looked at the genome data, and you could also see correlations, not just of correlations to externalizing disorders that were sex differentiated in males, but also some SNPs that corresponded to that. So here are some ways that we can actually use these tools, these neuroscience tools, to be able to answer some fundamental questions about the observations we're making in youth today. So what does studying children tell us about preventing and curing lifelong bipolar disorder? I have so many more slides to share, but I want to just kind of zip through some of these really interesting findings that we've done over the years. And specifically, just again, highlighting and celebrating that neuroscience tools can be very useful. They can actually differentiate a risk state from a disorder state. In this evaluation of youth with MDD compared to youth at risk for MDD based on a family history, the brain and connectivity profiles are completely different if you're in a risk state versus a disorder state. We can do fancy functional connectomic and evaluations using graph theory to help us understand the relationships between regions. And we just published this with our colleagues in China to demonstrate that high-risk youth parents with bipolar disorder really have different maps, functional connectome maps, compared to youth without any family history of bipolar disorder. And I started a study in my K ward, it's now been almost 15 years where we've evaluated healthy offspring of parents with bipolar disorder. And the first analysis looked at resting state connectivity in those high-risk offspring and found using ICA methods that, in fact, you have these very clear, again, coherent networks, including predominantly the ventrolateral prefrontal cortex and its connectivity to limbic and other prefrontal regions that actually predict functioning, get better and prune with age. So the older you are, the more connected the networks are, and also sex differentiated. It seems that girls are more at risk, boys are more at risk than girls. Girls are more at risk for disconnected networks. I can't see my slides very well. The other point that I wanted to make is a correlation with environmental factors. We looked at brain factors like connectivity in the prefrontal striatal networks and correlated them to chaos in the family environment, and predicted that chaotic family environments would lead to more disconnected networks. And lo and behold, again, in a sample of youth who have no psychiatric symptoms at all, at an at-risk state, completely healthy, you couldn't behaviorally differentiate them from any other kid on the street, yet their brain networks are so different. And that led us to do a larger study comparing youth offspring of parents with depression, youth offspring of parents with bipolar disorder, and healthy youth without any family history of psychopathology, 50 in each cell, and we followed them over time longitudinally. And what we found was that if they did have any conversion at 4 to 5 year follow-up, most of them were in the depression or mood disorder camp. So you saw really conserved, internalizing phenomenology that developed in this high-risk sample, starting again from a stage of health. But you have to follow these kids for a long stretch of time when you start evaluating them from a healthy state. We also found that these high-risk offspring of bipolar parents actually, again, at a stage of health, showed thalamic disconnectivity that was actually very similar to what we observed in adolescents with first episode mania. So thalamic activation and connectivity patterns might be an endophenotype for bipolar disorder that might be very specific. And here's my former graduate student, Akua Namarco, who did these analyses and demonstrated very clear impairments that not only differentiated bipolar offspring from depressed and healthy controls, but then also predicted that disconnectivity and deactivation while anticipating monetary rewards was associated with more baseline impulsivity and reduced social behaviors on follow-up. She then further demonstrated that weaker putamen and posterior cingulate connectivity during emotion processing was associated with more peer problems and increased risk for converting to some sort of a mood or anxiety disorder at follow-up. And Dina Fisher, a postdoctoral fellow of mine who's now on faculty at Stanford, showed that, really, again, you see more strong limbic and striatal resting state functional connectivity, distinguishing youth who are resilient on follow-up versus those who converted to a mood disorder, so that more connectivity reinforced, again, this concept that you were likely to remain resilient, whereas weaker connectivities for regions, for example, of the brain that process faces and face emotions show correlations with more rigid family phenotypes. So the kind of summary of those findings really suggests kind of very simplistically that increased baseline functional connectivity at rest and during emotion processing and reward processing characterize youth who are more resilient, whereas decreased connectivities seem to predict development of a bipolar or other mood spectrum disorder, I should say. And the stronger connectivity seems to also correlate with more pro-social behaviors, the capacity to make friends and keep friends. So the capacity to make friends and keep friends might be very critical in these high-risk youth. How can we teach them the social skills to help their brains grow? We can't just rely on climate change to do that for us. So secondary prevention strategies are where we ended up working in terms of with Dr. David Miklowitz, showing that if we actually do some secondary interventions like psychotherapy, in high-risk youth who present with symptoms like sub-threshold symptoms, could we actually change the brain? And this is one of the first demonstrations that family psychotherapy can actually have neuroplastic effects. How did we do it? We randomized kids to either having a psychoeducational intervention versus adding pro-social behaviors. And what we found was that the behavior training, the training that helped them have more functional relationships with their family members, with their peers, with caregivers, through effective communication and problem-solving skills, was a differentiator. And what's interesting here to highlight is that we didn't notice this in the acute effect of the treatment. It wasn't in the trial itself where we actually noticed the difference between kids who got family-focused therapy or just the psychoeducation alone. The result of these studies, actually the differentiator, came 2-3 years later. An important point, if you're going to test an intervention, you may not be seeing the effect immediately. You may have to wait 2 to 3 years to actually see what happens as a consequence of that. So following patients over time becomes very important. The brain also showed something really interesting. We saw actually kids who were randomized to family-focused therapy show increases in connectivity in prefrontal regions. And then we also saw that correlated with improvements in symptoms. We believe that that increased activation and connectivity, not just at rest, but at during emotion processing and problem solving, compared to just having a psychoeducation alone, likely led to, these are neural mediators of improved clinical outcomes. So we believe that there may be some, again, benefits of doing these interventions on brain development. So what do you do when you have a kid that comes with depression or anxiety, but doesn't have, bipolar symptoms at all? You treat them with psychotherapy first, but if it doesn't work, there's a concern that if you expose them to antidepressants, they might develop bipolar disorder or mania. We see that a lot of kids who have a family history of bipolar disorder plus younger age tend to be really at risk for antidepressant-related activation. So the younger the kids are, the more likely they are to have these arousal or activation-like symptoms that kind of look like mania, and you have to differentiate whether that's true. And we did this study actually looking at various risk factors that might predispose kids to developing activation and after exposure to an antidepressant. And we randomized high-risk offspring of parents with bipolar disorder who had depression or anxiety to Lexapro or escitalopram or placebo. And of course, we found very strong placebo response rates. Both groups got well in the acute phase. But we found very interesting differential responses in connectivity, whether patients actually had an adverse reaction or had worsening depression. So very clearly, again, imaging can be used. And we also did pharmacogenomics on them and found some very interesting risk factors for genetic influences on self-injury as well as side effects. That paper is now published and you can take a look at it online. And then, in terms of the tertiary prevention strategies, just to kind of remind ourselves that psychotherapy is really important for medication adherence. There's youth factors and parental factors that come into play that contribute to that. But in terms of pharmacological treatments in the US, we have a whole host of treatments that are available for acute mania management. But beyond that, we still have significant unmet needs. In Health Canada, it looks like only aripiprazole is approved for kids down to age 13. And what we've done in terms of analyses now of these clinical trial data that have been out for many years is looked at what are the symptoms that are responding most to these treatments. In this post hoc analysis, it was bridge symptoms between depression and bipolar disorder that actually really were quite responsive to a second generation antipsychotic. So sleep disruption and irritability seem to be highly sensitive and highly predictive. If you're responsive, if those symptoms respond early, it's very likely you're going to do well, not just in the acute phase, but also 2 years later. So there's a kind of a story evolving about whether patients respond well early on and whether you should keep them on medications. Should you choose lithium or a mood stabilizer? Now we're starting to do comparative effectiveness trials to help us understand the differences between lithium and SGAs. And there's some interesting data too on use of metformin adjunctively. And this is a pragmatic trial where kids actually had the option of choosing whether or not to be on metformin or just to take the lifestyle intervention. And this is a very large clinical trial that's going to be published soon. And the protocol for it is also published in JCAP Open. I know we don't have any time left, so I'm just going to breeze through and mention that college students are really at risk because they don't get to see they don't see the same person. And so Anthony's work in helping to bridge adolescence to adulthood is critical. And I think more practitioners should do that work. So kudos to you for that. And then patient centricity is important. We found when we did various analyses, cluster analyses, that clearly functional outcomes were very different in terms of predicting long-term outcomes overall compared to just symptomatic outcomes. So understanding those trajectories is important. We need better treatments because the current treatments that we have are not great and have side effects. And I really wished we had more time to talk about novel neuromodulatory treatments, because those are also potentially going to be useful for very difficult to treat depressions. And now there's some proof of concept that adolescents with refractory depression might be able to be amenable to these interventions. So though we have a tenuous risk-benefit profile, nothing good for anything bad, and we don't know how to prevent mood disorders from lasting a lifetime, we have our work cut out for us. And here's my sister, who inspires me in terms of resilience. She has Down syndrome and congenital heart disease. And she really helps me understand that it's important for us to know when to treat versus allowing adaptive mechanisms to kick in. And so with that, I'm going to acknowledge my village and thank you so much for your time. Appreciate it.
Great, thank you so much. So we'll take questions in the room, and the people on Zoom can put them in the chat.
So I have two questions, very brief. Do we have the hope that AI helps us find biomarkers? That's the first question. Second question, I had bipolar 2 for 15 years, and it took me 9 years to figure out the diagnosis. And to put it shortly, there was a ping pong match between anxiety disorder or bipolar 2 for 8 years. And it ended up being comorbidities. And so, but my gut tells me that actually, and I've never heard of this ever, that my low phases are a lot closer to anxiety compared to depression. And so I was wondering if you've ever seen a clinician or a researcher saying that like bipolar can be anxiety and mania as opposed to mood.
So those are two great questions. I'll answer the first one. AI, I think, is an unfolding process to understand its potential utility. My worry is of course, because we don't have great bumpers and real discernibility on the level of accuracy. I mean, some models are performing very well, and perhaps scaringly so, because they can replicate or recapitulate something with a very, very high degree of coherence. But I think the jury is still out about its applications in these settings. I would love to see us try and validate against some sort of, again, diagnostic gold standard, if it could be used to help facilitate. But we have to populate whatever AI is getting with, real and unbiased data. And that's, I think, a big challenge that we have to face. So whatever comes out, it's kind of like that garbage in, garbage out concept, and being very clear that what we are getting currently with whatever we have in our corpus, more broadly speaking, may or may not be reflective of true, real phenomenology. That then segues to your second question about bipolar 2 and comorbidity. I will say comorbidity is the rule rather than the exception, and can really delay diagnostic accuracy, in part because there's a recognition that this is a very important driver of unfortunately treatment seeking and relapse and difficult to treat. Anxiety comorbidity can make it very difficult to treat bipolar disorder because you've mood stabilized somebody and then you still have the anxiety to contend with. So have you addressed the underlying problem at all, if that's the case? I want to acknowledge that anxiety is a very important and common comorbidity in bipolar and unipolar depression. One of the things I'm really interested in is whether or not, like Lauren Alloy and Robin Nuslak's work is potentially useful, because they've looked at college students on dimensions that might lead to mania, kind of another risk population in the critical sensitive window when bipolar disorder really kind of very clearly takes onset. And what they found is that, there's a differential in terms of approach and withdrawal symptoms. And so anxiety is fundamentally a withdrawal phenomenon. And, so it doesn't surprise me that, in your experience, it seems to go along with the depressed phase of illness more. In mania, because you're increased reward sensitive, maybe novelty seeking, you have to overcome your withdrawal challenges and perhaps even overcome your anxiety to do grandiose things and have the energy and motivation to just kind of get over that hump. But that doesn't mean that underlying anxiety necessarily goes away. One of the things pharmacologically or in management that has me thinking about this is that I'll mood stabilize with lithium, for example, and then patients will come in continuously still anxious, but what they might actually be showing are mixed features that are very similar to what an anxiety, diathesis shows. In those cases, you have to understand whether you're adequately dosed and appropriately mood stabilized first, and then you could consider adding medications to help with the treatment of anxiety. But it's a slippery slope, and it takes a while to sort that out. So thanks for sharing your experience as well on that. I wish I had a better answer for you on beyond validating that it is true that anxiety is often co-occurring with bipolar disorder.
Thank you.
Thank you for the presentation, very interesting. You mentioned also very early prevention or detection, and you done some research where you have children of parents who have bipolar disorder, and I can imagine that there's a genetic load for that, so that will be a good population to test it. But for people who don't have a genetic predisposition to it, how early do you think we can get? Like, do you have to wait for some symptoms or for some episodes to occur and help people?
That's a general belief at this stage, that you wouldn't necessarily preemptively treat anyone who doesn't have any risk factors for bipolar disorder with anything, certainly pharmacologically. If there are some help-seeking issues, then you might. But really, those patients, the comparator group that looked behaviorally similar to the high-risk group, didn't have any issues and didn't really need anything and weren't looking for, and some of them did go on to develop depression. Very few, if any. I mean, the one patient that developed bipolar disorder in our longitudinal cohort over the 5-year period was in the bipolar risk group. And so we just have such few conversions in these prospective studies to be able to make any calculated conclusions. I will point you, though, to Danella Heffman's work in Pittsburgh. She's actually developed a risk calculator where you can actually take a bunch of clinical information and also potentially genetic and imaging information and develop somewhat of a heuristic on risk for developing bipolar disorder. And she's validated it in some capacity, at least internally. It needs external replication before we really hang our hat on it. But I think it's really elegant work to help us understand what's the general potential risk. The general potential risk out there is pretty low. It's not a highly prevalent condition. But the more prevalent attentional problems that are out there, again, create noise, right? ADHD, 10% of our pediatric population, right? And it's a very common first condition that might lead to bipolar disorder. How do you make sure that you understand that trajectory? And that's what waitful, watchful, iterative evaluation still at this stage.
Great, so we probably have time for one more question if there's one willing.
That's good.
Yeah.
So thank you for the beautiful presentation. We've mentioned evolution. It was super interesting that you mentioned. It's so ironic that now it's our big brain that is causing the climate change, and so we're the problem now. But regarding evolution, there's a few years ago, there's this really sort of interesting paper that talked about the genetic predisposition to bipolar disorder, and that it was sort of overlapping also with some actually very adaptive human traits. And that's might be why it actually in our species genetic pool, there are some genes that sort of go on because overall they increase our population's ability to be creative, to make links, to sort of be energetic and respond with in a way that is not necessarily pathological, but close to mania when faced with, acute difficulty or something that threatens to be depressive. So I wonder where we are with this research. I sometimes in clinical setting like to mention that this is, you share traits with people that
The
are very
greats.
creative, and so I'd like your thoughts on that.
It's an excellent question, Anthony. Creativity is clearly an important cornerstone phenotype for mania, and potentially very adaptive for many individuals who have this condition. Also potentially predisposes them towards more unfortunate outcomes, whether it's suicide or others. So, it's unclear to me like what the magnitude of creativity and the potential consequences of that and its correlates towards ultimate outcomes, I think is worthy of investigation. Your point about genetics and evolution remind me of a paper that just came out in Neuron that I'll share with you by a colleague of mine named Jack McClellan. He's in Washington State, in Seattle, and Children's, and he's been studying schizophrenia phenotypes for most of his career. And he believes that there is some genetic predetermination to the evolution of psychiatric phenotypes, and that it might be the case that we actually have these phenotypes for a reason, whether it's inducing variation or variability or some other phenomenology. Now, I can't think of a more variable phenotype than bipolar disorder. It's a moving target, over the lifespan, but it is something that, is worthy of continued investigations. Terry Ketter at Stanford did some work on this in terms of creativity, and there are some others who've looked at creativity in bipolar disorder. It is definitely an unmet need and an area to look at. Positive affect in general, I think, is important for us to understand, like, what are the boundaries between adaptive positive affect and maladaptive positive affect? Right, we think of it really the pro-social abilities, the ones that I was talking about training kids on, that really are supposed to be adaptive. It's supposed to create plasticity towards increases in brain connectivity in regions that are really important for social cognition, but also for emotional regulation. But what would be the value of that, and to what extent is it adaptive, beyond which, it's potentially maladaptive? And I think that's where orphan diseases can really inform us a lot, because Prader-Willi and other neurodevelopmental disorders actually have very variable social phenotypes that could help us better understand, sort of the continuum of these from a conserved genetic perspective, right? You actually can isolate the genetic deficit and then correlate it with behavioral phenotypes. That being said, orphan diseases also struggle with the same heterogeneity problems as any other psychiatric disorder. So we have some work cut out for us that you all will, of course, solve as soon as possible with all of you engaged in this work. So please keep going and keep thinking about these questions, and hopefully we can continue to collaborate as well. Thanks.